began in, I believe, in 1493, not 1492 when Columbus discovered the New World. It was when he returned from the New World and communicated that to Europe and the rest of the world. It was these new understandings that propelled the Renaissance. And the Renaissance is characterized by a proliferation of new ideas in an atmosphere in which inquiry was finally fostered. In transition out of the Renaissance, we entered into the Age of Enlightenment. And the Age of Enlightenment is characterized by new technologies. And I think last year was 1493, when these dentists came and spoke to NSTA and informed us of their radical discoveries. It is a tip of an iceberg. It's a whole new world of medicine that we're looking at. And those of us who have suffered from dystonias, including myself, I think are recognizing this. The technologies that we're seeing are the beginning of a new revolution. And to fuel that, we need to infuse medical science with basic research. And this is something that NSTA is doing. It's remarkable. Our patient organization only has a research budget of $20,000. And that was accumulated, if I'm not mistaken, over about 10 or even longer years.
Yeah, about a dozen years.
About a dozen years. And with that money, we have pulled together this amazing new synthesis of information. We've brought in new partners, Gary, Tony, Laurel, and Ken has been the quarterback on this. So I say he was the tall man with the big heart, so we should acknowledge him for that. And I've often said that if I don't see eye to eye with Ken, it's because he's about an inch or two taller than I am. So I'm going to try to end up the conference by pulling things together. I have a colleague at Stanford, he's Elliot Crane. He introduces himself as a pediatric anesthesiologist. He puts children to sleep for a living. But he also says he's an academic and he puts audiences to sleep for free. Now, I describe myself as somebody who doesn't want to become a lecture vending machine. I'm a professor at the University of Washington. I tell my students, you can't put a quarter into a professor and out comes a 50-minute lecture. So I'm going to try to get done before my allotted time and allow you to talk and interact. And I also, during my talk, like to keep things alive by having people interact. And so I'm going to call upon some of you to participate. So this is the same title I've used for the third year. Now this is amazing, Injury-Induced Dystonia. And the title doesn't change, but the content does. And I'm integrating what you've been seeing here today. Okay, these oral orthotics, other groups are using them. This is published in the prestigious journal Movement Disorders. And this is a woman with oral mandibular dystonia, and you can see also involves her eyes. She has blepharospasm. And she puts in an oral orthotic, it fits in her the lower jaw, the anterior portion of it, and within seconds, her eyes open up and her mandibular dystonia goes into suppression. So this is antagonizing the movement disorder. And this term, guest antagoniste, was a term that Jean-Martin Charcot, the father of neurology, coined in the 1880s. So it goes back that far, that we know that I can look out and see, many of you are using sensory tricks to suppress your symptoms. So part of these actions is very likely to be a sensory trick, and I'll give the evidence for that. But as Dr. Sims and Emergent is saying, there's more to it than that. And that's because of the entrapped nerve in the TMJ. And so we need to talk about nerve injuries, neuropathies, and what happens with neuropathies and how they're connected to the brainstem and beyond. Now, if you go to a neurologist, part of their work is they're going to tap on your tendons. And they're doing that to give you an impulse, bring you to threshold, and get a reaction. And if they don't get a reaction in your lower extremity, a little red flag goes up in their mind and they're going, I better get a bigger reaction. And what they do is they have you do this. Link your two hands together and pull apart. And then they tap your tendon and they get a big knee-jerk reaction. And this is called the Gendrasik maneuver, after this fellow over there on the right. And in the 1880s, he was a young neurologist, and he became famous because it showed that a voluntary command, a segmental action, could cause profound changes in tendon reflexes everywhere in your body, including your knee jerk. And so when we talk about connections, interconnections, that's what we're seeing. Action here influences things down there. And it's doing so by going through your brain. And this is very important because what I'm going to draw together is what's current understanding about the Gendrasik maneuver. And one of the things here is that whenever you see this, you go, how could this be true? How could I put something in my mouth and shut off this debilitating movement disorder within seconds? How could we shut off Tourette's or tremor or attention deficit disorder or impulses that the Tourette's patients have? Oh, how will they know disappear within seconds? You're changing brain activity by doing things like the Gendrasik maneuver. And part of it is at and I'm not going to go through all the diagram, but part of it's at the segmental level. So you hit your nerves, your tendon, your patellar tendon, it stretches some sensors in your quadricep, your muscle. It fires off a nerve, goes into your spinal cord, and then comes back, triggers the quadricep to contract, and now goes your knee. But there's a longer loop that goes up into your brain. And the Gendrasik maneuver does two things. It suppresses that longer loop. At the same time, it enhances the segmental loop. So there's a rapid, short latency thing that goes through your spinal cord, and that's enhanced. And then other signals are being changed up here. Now, I mentioned Charcot, father of neurology. He worked at an insane asylum in Paris, the Salpêtrière, and thousands of women were placed there who were destitute. And so he saw everything. Dystonias, Tourette's, schizophrenia. He segregated them into different categories. Those he couldn't figure out, he put into a bag called hysteria. And let's read from his words. Hysteria has its laws, its determination, precisely like a nervous ailment with a material lesion. That means a structural lesion. Its anatomical lesion still eludes our means of investigation. So he was teaching his students, which included, let's look at Babinski, of the Babinski sign, Gilles de la Tourette was his student, Binet, Stanford Binet intelligence test, and not shown there was a young neurologist from Austria, from Vienna, Sigmund Freud, who studied hysteria in women when he was there for 5 months. So Charcot's views had profound impact on the history of neurology. And some of his patients, one of his patients was known as Augustine. And she had what he called hysteria major, 1,000 hysterical fits a year. We now know that this is probably temporal lobe epilepsy, which one of our speakers talked about today, his brother suffered from. Now, this type of seizure can produce bizarre, rapidly changing signs, including dystonic postures. And you can see Augustine in a whole body dystonic posture. In other cases, she's completely fluid and moving around, but she's having hallucinations and very rapid mood changes. These seizures, the temporal means to the side. There's a place called the hippocampus, and it communicates to the amygdala, which is the gateway to the limbic response. If you're having a seizure there, your emotions are going to be going all over the place. When she wasn't having a seizure, she was sane, but she entered periods of insanity when she was having these seizures. These postures are called ictal dystonias, and it means that you're having too much excitation and also a breakdown in inhibition. You co-contract. And you can see her suspended between two chairs there. Sometimes it's only half of her body. All of this rapidly changing stuff, now we can pull this disorder, temporal lobe epilepsy, out of the bag of hysteria and say it is a known physiological disorder. In actuality, it looks to be a neuroinflammatory disorder. Inflammation in the temporal lobe may be setting this off. Blepharospasm. Here's a woman with hemiblepharospasm. You can see down below, blepharospasm hysterique, viewed as another form of hysteria. So these are the origins of these psychogenic origins of these disorders. Justine Echeverry, I would like every medical school in the world to have a grand rounds in neurologies and review Justine Echeverry's case. She convulsed, passed out, fell into a fire, burned one of her eyes, lost sight, scarred her face, lost all of her upper teeth. All three branches of her trigeminal nerve, the fifth nerve, would have been injured. What would have happened to her brainstem? That nerve would project into the brainstem. You'd probably get inflammation going on there. Would the inflammation spread to other parts of her brain? Possibly. But at that time, and you've noticed she has a fixed contracture, a fixed dystonia. All four limbs of her body eventually became fixed in posture. One day she had a convulsion, and she began to speak. And she said, I want to walk. And within 3 days, all of her symptoms disappeared. Charcot thought it was a religious getting caught up in a religious experience. Could be that the neuroinflammation that was going on in her nervous system had finally calmed down, and that the convulsion may have helped reset things and allowed her to begin ambulating again. So these postures as signs of hysteria, the sphinx of the neuroses, these unknown neurological disorders. But what he postulated was that there were dynamic lesions in the brain, in the nervous system, that they couldn't see yet. Not structural lesions, because he knew that the symptoms came and went. Structural lesions leave you with permanent deficits. So he postulated dynamic lesions, which we can now see through modern imaging techniques. It took a whole bunch of Nobel Prizes to do this. Physicists, chemists, doctors, coming up with positron emission tomography, and as we heard earlier, single photon emission computed tomography, SPECT imaging. This is a Korean boy who, when he exercises, after about 30 minutes, his foot, only his right foot, goes into dystonic posture. It's about 30 minutes, and then it pops loose. Okay, when he's in the dystonic posture, if you use a radiochemical that looks at blood flow changes, look at his brain. His somatosensory cortex has a hot spot, and so does his cerebellum. When he pops out, those signals disappear. They ask him to hold his foot and mimic a dystonic posture. That's the lower right panel. No signal. So, here's a technique that can distinguish whether you're faking it or not. Okay? Is it all in the mind? Certainly in the motor cortex, but also in the cerebellum. Our views of psychogenicity are really outmoded. The distinguishing between whether it's psychologic or physiologic, a number of neurologists are saying this is no longer a productive way of thinking. We need to move on to mechanistic views of how the disorders are being generated. And that takes us into neural circuitry. One of the people who looked at that originally was back in the Civil War, Silas Ware Mitchell, who wrote a very influential book called Injury of Nerves and Their Consequences. And he described a horrible burning pain, and this was described in a patient of his who was wounded at the Battle of Gettysburg. A mini ball went through his clavicle and exited the posterior part of his right arm. And 6 months after the battle, he writes, "The burning in his right hand is intense and constant. Both hands are covered with loose cotton gloves, which he wets at brief intervals. He is especially fearful of having the right hand touched, is nervous and hysterical to such a degree that his relatives suppose him to be partially insane. It is difficult to examine him properly on account of his timidity, and his whole appearance affects the appearance of pain." This is known as complex regional pain syndrome, induced by nerve injuries. This is a soldier in World War II, which was hit by a bullet that passed through a nerve. It's one of the most extreme forms of pain known to medicine, and it is known as the suicide disease among the people who have it. 50% of the patients with CRPS ideate suicide, 15% act on it an average of twice. So this burning, constant, intense pain is unbearable. And yet, back in 1864, a year after the Battle of Gettysburg, something rapidly changed. The soldier began to lose the violent pain. It wasn't gradual. One day, the soldier woke up, and suddenly his glove was dry, and he could use his hand well without pain. Rapid onset, rapid remission are characteristic of this disease. What's causing it? Neuroinflammation is now being established as a central part of the etiology and mechanism of this disorder. So I'm going to talk to you quickly about neuroinflammation and sensory and motor disorders because I think many of you are suffering from this. I think there's a smoldering sites of neuroinflammation in various parts of your nervous system. CRPS, okay, the wet hand, is characterized by excessive sweating, extreme pain, edema, swelling. Also, vasomotor changes. The skin in an infected area can turn blue if it goes under vasoconstriction or red if it dilates. Also, fixed postures, dystonia. 50% of CRPS patients that have a defined nerve injury developed a fixed dystonia. Those that have a broken bone, it's 25% if you have CRPS that comes from an origin other than a nerve injury. No other pain disorder do you find this high frequency of dystonia. For those of you who have cervical dystonia, this is a sister disease to your disorder. And I serve on the medical advisory board of NSTA, and also I'm on the board of directors, and I co-chair the scientific advisory committee of the Reflex Sympathetic Dystrophy Syndrome Association, which is dedicated to the understanding of CRPS. I wanted to join both organizations because my daughter suffers from CRPS, and she has had numerous dystonias, both legs, both arms, abdomen, throat, eyelids. She was bedridden with the disease. Through a year of physical therapy, we got her walking again. Within 3 years, we got the symptoms into remission. Now she's recently swam 1.25 miles in 45 minutes. She's a violinist in her middle school. So 4 years ago, you wouldn't have guessed that that would be possible. So I offer a personal view that these dystonias can be reversed. And I see these oral orthotics as one of the systems that we can use to help reset the system. So what is neuroinflammation? Inside your nervous system, you have a group of resident immune cells. They're like your National Guard. They sit in there and patrol. And whenever there's an injury to the nervous system, they go on alert. And what do? They look for pathogens, look for invaders. They also send out chemicals that keep neurons alive. So one way to provoke them into activity is to take a needle and stick it right through a nerve. And if you do this in a rat, what you'll find is where those neurons project into the spinal cord, that group of those, they're called microglia, the resident immune cells, will become activated. And one of the things that you see from these types of needle sticks is the rat will develop a fixed posture. You'll see that in its right, or the rear left foot is in a fixed curved posture. This is in a paper by Anne-Louise Oaklander, and she has a patient there with CRPS, and you can see the foot in a dystonic posture. This came from a vein stripping. That was the injury that set this off. So the exciting thing is that we now have a defined animal model to produce this type of post-traumatic fixed dystonia. Having an animal model is really key for us scientists to interface with doctors and to interface with patients. I want to give you a view of what active microglia do for you. And every one of us has had this happen in our life. Whether we had the flu or we had a tooth removed, okay, these microglia get activated in a variety of situations. This is a brain slice going to be injured with a laser beam. This is a friend of mine at the University of Iowa, and you'll see in this movie, okay, there's the laser beam, boom, the cells send out their processes within minutes. The red are dying neurons. They're dying from the laser beam. Okay, there. See how active they become? The cells retract their processes. They become amoeboid. They're moving towards the injury site. They're looking for trouble and trying to keep the nervous system alive. Okay, this is what I think goes on when you injure a nerve. This is what I think goes on in your brainstem when you have a TMJ problem. So Tony Sims, Brendan Stack articulated the idea that this auriculotemporal nerve, which is a branch of your mandibular nerve, is getting compressed and injured. That's a neuropathy. What happens when a nerve gets compressed, irritated, becomes inflamed? It can send signals into the spinal cord, in this case the brainstem, and what happens is you activate microglia. And this is known now from animal models, that the spinal trigeminal nucleus, one of the areas that Dr. Sims was talking to you about, these cells become activated. So, changes in cell behavior. They send out chemicals that alter the way the neurons fire. So this means once you get these cells talking to each other, the conversation changes and the function changes, meaning that the neurons are going to be misbehaving. So a pioneer in the area of imaging neuroinflammation, Richard Bonatti, looked at a number of different neurological disorders. And what he discovered is that you may have injury at the spinal cord level, setting up inflammation, but it may then spread up into your brain, into an area called your thalamus. And he did a study with 7 people who had chronic pain, an amputated limb or peripheral nerve injury. And he found out that some people, up to 2 decades after they had had a nerve injury, still in chronic pain, had inflammation in their thalamus. So when the doctor said it's all in your head, they were right. But they had no idea what was causing it. But now we have an idea that there's a smoldering inflammation going on there. So we need these imaging methods to see where the inflammation is, but we also need the science to figure out why is it persisting and how do we turn it off. This is a recent review showing basically what I just told you. Peripheral injury can cause glial activation in the spinal cord or brainstem, and then it can move through axonal processes somewhere else and get established at a secondary site. This may be why you're different than other people. How many people think their ST was caused by a peripheral injury? Don't know why their ST appeared. Okay? Not the same. Okay? That's what some people reviewing the field now say. It's about half of dystonias are now preceded by some type of trauma. Where's the memory? Okay, it's not necessarily psychological, it could be immunologic. So Bonatti said, okay, you injure a peripheral nerve, that projects into your brainstem, where we expect inflammation to be established at the first order synapse. But inflammation, in a minority of cases, could spread to the next synapse, which may be from up here, the second order synapse. So this is the thing that we need to start looking at. We're advocating that people with ST be scanned the same way as these chronic pain patients to look for inflammation elsewhere. Because inflammation, say in the thalamus, can begin to change your somatosensory map. I like to call it the GPS map of your body. So your body image is mapped onto your spinal cord, and that map is relayed to the thalamus, and that GPS map is mapped up to your cortex. And you use those maps for good reasons. You send signals, you process, and you send out commands. What would happen during the holidays if your GPS map for a city was distorted? All the UPS trucks would be delivering packages to the wrong locations. What happens if the mailman was doing that? Or if the timing was off? Then your bills wouldn't arrive at the first of the month. All of a sudden, the whole economy, the information processing of the system would collapse. So, what if inflammation not only spreads from the spinal cord up into the thalamus, but let's go to other places, like the motor cortex. Now we have 2 sites of dysfunction, spinal cord, motor cortex. What if it goes into the red nucleus, which controls your posture? What if it goes, okay, so what would you get? Well, CPS patients get these fixed postures. You also get those with post-traumatic dystonia. Another one is it goes the opposite way. Rather than tonic contraction, you get weakness. How many of you have had periods of time where your ST manifested itself just by flaccidness? Anybody had that? Okay. So when a neurologist sees that, they go, this is a functional disorder. And depending on the training, they will see it as different. Many of them will say, that's a code word that some psychological factor is producing this. Another possibility is that the inflammation is moved from the spinal cord into the reticular formation, the place that Tony Sims was talking to you. Up there are a bunch of inhibitory neurons. If you disinhibit inhibitory neurons, they're going to send out a lot of inhibitory tone, which is going to make your muscles weak. And you're not going to be able to generate postural tone. You may end up, I believe, with things like a drop foot. And when a neurologist tests, are the nerves all connected? They find that they are. But what you end up with is a functional weakness. So, to understand these, we need to look at changes in the brain map, the GPS map, and that's called somatotopy. And so, if you have a disorder, and I suspect many of you do, I would say you have a somatotopic disorder. Where that somatotopic disorder is, whether it's in your thalamus or your somatosensory cortex, that's what we need to find out. And there are ways to do that. And there's ways to treat it with sensory inputs. Sometimes just looking at a computer screen, looking at a limb and in various orientations helps you move your body into that location. And these are the types of therapies that are being used successfully for the treatment of CRPS movement disorders. Okay, let's take, somebody talked about, Bell's palsy. I think it was your patient. Okay, Bell's palsy is 7th cranial nerve. Oftentimes there's irritation or entrapment where it exits the face. It swells up. And then the neurologists aren't worried about it because usually they say it's self-limiting, means it's going to get better within a few months. So if the inflammation goes down, swelling will go down, and function will come back. But here's the difference where we're at. We know that Bell's palsy is a peripheral nerve injury, okay? And we know statistically what's going to happen. But what's the mechanism? Why do we get paresis, weakness, sometimes twitching? So this is mechanism. And this is where neurophysiologists have to jump in and try to figure out, why is this occurring? So Bonatti did an experiment with a rat. He cut the facial nerve, and he found out that where it projects into the brainstem, he gets glial activation, neuroinflammation. So again, cut the nerve here. Now you've got inflammation going out of the brainstem. So let's just put those up over there. What happens if the inflammation jumps from the first order synapse to the second? So let's put that in. Okay, and now what's going on there? When you have inflammation, things begin to happen in the neurons. One of the things that can happen is their chloride gradients can collapse. And a lot of the stuff that keeps us from twitching and contracting are inhibitory neurons that use chloride gradients. These chloride gradients across their cell membranes. When you have inflammation, those chloride gradients collapse. That means your inhibitory tone drops out. At the same time, you may get excitatory tone revving up. So let's imagine what happens when you have disinhibition at two sites. Your command neuron is firing away, and then it hits your motor neuron in your spinal cord. What type of reaction would you expect? Realize that these neurons innervate the muscles of the face. What would you predict? The equivalent of cervical dystonia, right? So this is called hemifacial spasm. So this is why we need to be able to image and find out in an individual patient, is there inflammation at these various sites? Okay, so Bonatti has helped us understand that inflammation can move from the spinal cord into the brainstem and also the thalamus. We also need to think about people with ST. I first got associated with NSTA by seeking out Karen Fry in Fountain Valley because she had written an excellent paper with Daniel Chirag on post-traumatic dystonia. And this is a railroad worker who had popped up a spike, his head popped back, and what they describe in the paper is almost immediately he began to have his neck pulled to the side. Not hours, or not days or weeks later, but immediately. So this tells us that something fast has to be happening. So perhaps during that injury, he had a contusion in his motor cortex, producing neuroinflammation. But why don't we all get that? Why boxers, or when you stand up into a cabinet, why don't we all end up like that with ST? Well, again, it may be having two sites of inflammation, which may be key to locking in the dysfunction. To make an analogy, if you're driving a car, if your steering wheel or your brakes go out, you still have a chance of surviving because you've got some other place to control the system. But what happens if the brakes and the steering wheel go out at the same time? Only James Bond could make it through that.
Yeah.
So when you have 2 points of dysfunction in a feedback system, Ken, who makes, I'm not going to say what type of satellites for our country. It's a secret.
It's not a secret.
Okay, they're spy satellites. Okay.
Spy satellites.
Okay. Security satellites. They're security satellites.
Secure, yeah.
Ken and I had a lot of good conversations. You can't have a system that depends on feedback. If you have 2 points of dysfunction, it's going to decompensate. So this is the language of engineers, but realize that only 3% of the population are scientists and engineers, so forgive us for our language, right? The way we communicate. Okay, CRPS, why is it so bad? Turns out that 90% of patients with CRPS have been found to have autoantibodies. It means it's like lupus or multiple sclerosis. But these autoantibodies attack neurotransmitter receptors that are present on autonomic neurons and enteric neurons. And so it looks to be a neuroimmune-mediated autoimmune disorder, or autoimmune-mediated neuroinflammatory disorder. So where do these antibodies bind? Sympathetic ganglia, spinal cord, viscera like the heart. These receptors are everywhere. Cerebellum, brainstem. CRPS patients have dysfunctions in all these locations. In the motor domain, spinal cord, motor cortex, and motor neurons. So, why do CRPS patients get dystonia so frequently? It may be because this is a multifocal autoimmune-mediated neuroinflammatory disorder. So this is the importance to you all. What makes your condition similar to the people that have fixed dystonia here? It may be a neuroinflammatory basis. And that's what we need to use as a hypothesis. It hasn't been confirmed yet. What we're doing is working to see if we can find out whether that's true. People can persist in these fixed postures for years. They're very painful. On top of that, you have severe pain. The way they treat it is to give you a very cheap anesthetic, very powerful one called ketamine. It's an IV, about 2 hours a day, in 4 to 5 days of these infusions, miraculous things happen. This is a friend of mine whose hand was in this fixed dystonia. After 4 days of ketamine infusions, her hands opened up, a rapid remission. And ketamine blocks a neurotransmitter receptor called a glutamate receptor. It's thought that it downregulates the expression of this receptor, which means we have to think about genetic switches. And we have to think about genetic switches in you too. These neuroinflammatory states require multiple genetic switches taking place in the immune cells, the neurons, and this is how the memory may be established. The good news is ketamine can pull these people out of these fixed postures. So I asked the question, would ketamine infusions be effective for post-traumatic dystonia? Raised your hand. So this is a hypothesis. This is where science comes in. I'm not a doctor. There's risks, but there's also benefits. And for those who are stuck with these post-traumatic dystonias, okay, this is working for the CRPS community. What we need to do is dialogue into the other parts of the dystonia world, whether this is a possible treatment. I mentioned distorted GPS maps. Those are known in CRPS patients. The affected limb is expanded in the brain. In fact, when you ask a CRPS patient to diagram where their limb is, they say it's here. When they close their eyes, that's their perception of the world. In fact, even a person moving into that space causes pain because they perceive that you coming into their perceived part of the world is touching. Now think what a psychiatrist or psychologist would make of that. I reach out to touch this person and they scream in pain and say psychogenic. But your visual system is comparing its world with this map, and the map is distorted. And so you trigger off appropriate physiological responses to the sensations that you're getting. So it's it's not an aberration in a way, because your map tells you that there's danger, and your body, the rest of your body, is responding that way. So CRPS patients have it's a very instructive disorder. If you show CRPS patients ambiguous visual stimuli, like this picture, that cube, you show them the square, no pain. You show them the cube, they experience pain. That's because the cube can be viewed from two different angles. And this is a very basic part of recognition, very low-level recognition. Another test that they do is they show you the duck rabbit. You see the duck rabbit? See the duck, then the rabbit? Does that cause anybody pain? No. But for CRPS patients, it causes pain. And there's a part of the brain that deals with conflict. It's called the anterior cingulate. And it drives the midbrain, which is where anti-pain signals are generated, part of it. So if you've got a dysfunctional anti-pain system and then you trigger it off by this ambiguous conflict, you can cause pain. And not only that, they find 30% of these patients develop fixed dystonias by looking at the duck rabbit. Now, is that psychogenic dystonia? I would call it psychophysiologic coupling. That the psychoperception interacting with the distorted map is creating a misinterpretation of signals, creating these postures. Okay, so you heard about the TMJ, the trigeminal nerve, and the auriculotemporal nerve, and you saw this woman here. I had a dystonia like you did 30 years ago when I was in graduate school. After running and somebody handed me a heavy object, I pinched my side of my chest, and then I bent over and I got stuck for 6 weeks in a posture that looked like that. Very painful, as anytime I tried to pull against it, it would pull back. And when I first met Ken, I asked him, did you ever have that experience that you pull against your contracted muscle, that it pulls back harder? He said, yep, common experience. And my girlfriend, who's now my wife, coached me to get up and walk. And very painful, but eventually, one Sunday, it just began to relax and remit quickly. I've seen these type of dystonias in myself, my father, my mother, my daughter, my brother who had idiopathic scoliosis. I watched him spasm until they put him in a back brace. His kids and his granddaughter all have it. We have some autosomal dominant characteristic in our family that sets us up for these things. So there's a genetic component that can be modified by injury. I mentioned the Gendrasik maneuver. Janelle, can you come up? So I've been talking to some of you. Neurologists will ask you to do this for free. Good thing they don't charge you for doing the Gendrasik maneuver. So hop on up here. So you have an ST, which is okay. So turn and do the Gendrasik maneuver.
Now ordinarily I can't turn left very well. Of course, I can't stand like this all the time either.
Yeah, but you could put an oral orthotic in your mouth and bite down, because neurologists will often ask people, if the Gendrasik maneuver doesn't work, just to bite down, and that will enhance the deep tendon reflexes, but you're changing brain activity. So Janelle, you and I, let's ask everybody to do this, to wake up, and then I'm going to end quickly, but let's do the Gendrasik maneuver together. Okay, pull, and those of you with ST, try to move your heads and see if you get more mobility. Okay, anybody have a good experience? Okay, so talk to Tony and Gary, because I think you'll respond to the tongue blast. Thank you, Janelle. Okay, yesterday, before I flew here, I was meeting with 3 dystonia patients, their support group in Albuquerque, New Mexico. One of these guys had a very rare disorder. It's called a paroxysmal kinesogenic dystonia. Does anybody have that in here? I doubt it. So it means that when he begins to walk, he begins to spasm. And he developed this after a car accident 12 years ago. And So he came to a conference that Tony Sims and I attended last week, and Tony looked at him, got the tongue blades, put them in, and this guy's hand opened up, began to flex, he threw his cane on the ground, and began walking normally. And it was quite shocking, I know, to not only the participants, but especially the neurologists that were in the audience, because they were peripheral nerve experts. Okay? And yesterday, I brought some 12-pound dumbbells to test him out. So we put in the tongue blades, and he could lift them up and do it better than I could. Then we took him out. As he began to lift up the dumbbells, it began to trigger him off into a dystonic spasm. He collapsed into the chair, and I was able to pass him the tongue blades, and he put them in his mouth, bit down, and he was able to turn off the spasm like that. Now, I'm going to say that this isn't new stuff. Okay, this is natural. This isn't me when I was young. Okay. But what's he doing? He's teeth clenching. But he's also doing, I think, the Jurassic maneuver. Look what he's putting the pressure on his hands, right? And then he's obviously pretty well toned to lift 1,000 pounds off the ground. Now, I could look like that if I was trying to do 50 pounds. All right, 40 pounds. But you do this when you want to block your sensory system, when you're in intense pain. And women going through labor, in many cultures, they use a piece of rope or a stick to assist in that. When I was 14, I had broken my elbow and I had a 5-inch pin in my arm, and they were going to pull it out. And they gave me a rolled up washcloth to bite under. And they began pulling that out with the pin with vice grips. And it felt like a bone was being pulled out of my arm because it was still attached to the bone with all the adhesions. It took about 30 seconds for them to pull that out. That was worse than the break. Okay. But as I was biting down, I also tightened up my intercostal muscles, and I made it through. And they congratulated me. They said, "You're the second person who didn't pass out on us." And the other guy was screaming, and he was twice your age. I was 14. And I said, I had to confess, I was screaming on the inside. And they said, "Oh, it's okay to scream on the inside." Now, what prevented me from passing out? Biting and tightening my intercostal muscles. Notice that in those films, when these people get the oral orthotic, they're able to breathe more. It's not just here, it's here. How many people put their finger on their nose to block a sneeze? I do. How many people yawn in the morning to? Because that's what you are. You're paralyzed in REM sleep. And to get going, you stretch. You're gone. You're stretching these muscles and tendons in your joint, and you're stimulating your brainstem. And there's a nucleus called the locus coeruleus that gives you a little squirt of brain adrenaline. It's called norepinephrine, and that's what wakes you up. So we use sensory tricks all the time. It's natural. That's not natural, but he's using it for enhanced purposes. Sensory tricks. Here's a great paper that just came out, Movement Disorder. Parkinsonism and hemichoreoballism, 2 case studies where they're using sensory tricks. Pressure on a rhomboidalis muscle in one case, pressure on the base of the skull in the hemichoreoballism case. Shut off the symptoms. Gary's telling you that he showed you with the Parkinson's patient. Using the orthotic, they can move more quickly. So this is a whole new world. It is the age of enlightenment. And the neurologists, it's an exciting time for them because it's an age of awakening, because they're rediscovering things like the Jurassic maneuver in a different context. Now, how normal are we? I always ask my students that. Who's the most normal in here? Nobody raises their hand. And I say, who's the most extreme, the most likely to become a new species? Nobody answers that. Oh, okay, the outlier. Okay. So we all have our deviations, our deficits, right? 8% of the world, including me, have a condition called voluntary nystagmus. That means your eyes oscillate. I can turn it on and off. It will. And anybody who wants to see that, after the break, I'll do it for you. Okay? And it'll freak you out at first. But it involves cranial nerves 3, 4, and 6. If I do the Jurassic maneuver, I can antagonize it. If I do teeth clenching, I can antagonize it. I can also touch it with my cheeks or my temples and antagonize it. So my trigeminal nerve is a pathway to controlling a movement disorder. Now, Ken said we are trying to get some science going on this, and we're partnering with Vince Clark, the University of New Mexico. He's a functional MRI expert. And this is me, my brain, doing voluntary nystagmus and teeth clenching, just like the tongue plates. So we take one set of data where I repetitively generate voluntary nystagmus, and we put it over here. Then I do voluntary nystagmus while I'm clenching, and I turn it off. And they take that data set over here. Then we subtract the two images, and that's the difference that you see as a function through my brain. And what you'll see is that the right lateral cerebellum lights up in some other spots. And what we're doing from this is I can show you that my brain activity does change when I do my sensory tricks. And it antagonizes my movement disorder. It means this modern technology can be used to dissect this therapy. And with that, we think that the acceptance of this as a modality for treatment should increase. It puts some scientific mechanism to what's going on. And Dr. Pathak, you brought up the issue of migraine. This is exactly what he was talking about. Trigeminal nerve. Not only does it do reflexes for your blink reflex, okay? A puff of air goes to your eye. They do that to the ophthalmologist. Remember, they do that to you? They sneak up and you blink, okay? That's going through this trigeminal nerve, trigeminal nucleus. But there's a reflex that involves vasomotor dynamics. And remember I talked about CRPS patients have abnormal vasomotor behavior? Those people who suffer from migraine have that. It's on the covering of the brain called the dura. And you can end up with an inflammatory process out there that makes the blood vessels hypersensitive. It may be the nerve endings are hypersensitive. So little triggers, like too much light, too much stress, sets off vasoconstriction, and through this reflex arc, which involves the brainstem, the trigeminal nerve, horribly painful. Seek medical treatment, avoid the stimuli. Okay, this is not considered to be psychogenic. It's considered to be a physiological process. But I think it has significant overlap with the phenomenon that you all are dealing with, whether you experience it or whether you're a caregiver. We just came from a meeting that I co-organized in Albuquerque called Imaging, Neuroinflammation, and Neuropathic Pain. And the goal was to develop the imaging methodologies to look into the living brain, like Richard Benanti did 10 years ago, and look for sites of neuroinflammation. There's now genetically engineered rats that glow in the dark. They have firefly genes. So whenever there's inflammation in the nervous system, they turn them on. So you put the anesthetized rat in the box, and you can see where there's neuroinflammation. So we want to now look at cases like this man, this railroad worker who had a post-traumatic dystonia. How can we do it? If we just take a needle and injure a nerve, either in the leg or in this case for ST, I think a cervical nerve, and look at one of these rats, we can then begin to image where the inflammation is. Is it at one site or two sites? And then we can use the rats to give therapies. And this is where, whether it's Botox or pharmacological agents or physical therapy, and I've talked to Tony about making an oral orthotic for a rat, but he's scared to put his hands in the man's mouth. Okay? But it's possible. Okay, end up SPECT imaging. Okay, this is a woman who had whiplash injury, and she had chronic pain in her neck. They developed a new radioligand. They don't know how it works at the cellular level, but it lights up a hot spot in some fat tissue next to her spine, right where she's having horrible, debilitating pain. So molecular imaging, using these techniques, offers us the ability to find these spots of hidden neuroinflammation. And one of the outcomes of our workshop was to develop the techniques to go into the human spinal cord and brainstem to look for this. And that's what RSDSA was looking for partners. And actually, since I'm on both boards, NSTA is there too. So we are working together as part of a large consortium to develop means of looking into the brain. And the Associate Director of Brookhaven National Labs has developed a very cheap, handheld gamma ray camera to do the SPECT imaging. It's only $40,000. So we see that this might move into movement disorder clinics. So imagine, you take a radioactive chemical, wait about an hour, the doctor scans you, they're scanning a mouse, but now scans you and looks for sites of neuroinflammation. If you've got them, they'll send you off to the big machine for a much better image. But this is the new type of modern medicine that we're looking at. To make it all happen, we're building an international neuroinflammation knowledge consortium with focus groups, which include neuroimaging, neuroinflammatory mediated movement disorders, autoimmunity, medical education, and outreach. You can't do it alone. No matter how much I studied, I couldn't be a dentist. I couldn't be a filmmaker. I couldn't make spy satellites. Okay? We need all dialogue and work as a team. And what's been great this last year is that I feel like we've been coming from the new world, and this is 1493. Well, actually, 1493 was last year. It's 1494. We're building a community where we have communication and cooperation. And I just want to end by showing a picture of one of my friends who was in desperate shape, and she has CRPS with dystonias that are very crippling. She was in the hospital 3 weeks before this, and I said, you got to go down and see Tony Sims. And she goes, I can't move. I said, go get a wooden spoon from your kitchen. She did. I said, bite on it. She goes, this is making me feel better. And I said, go as soon as you can to Big Five Sporting Goods and get a mouth guard to stabilize your jaw. She did. And a few days later, she was down at Tony's office, and Tony was giving her some tongue blades, and this is what happened to her. So this is a person who's having a dystonic spasm. So I'm going to find where the voice or the sound is. So you've seen it for yourselves today, and I think I'd just like to give my personal appreciation to Tony and Gary for bringing this to us.